excellent contribution to BMT society, except, especially being a figure in transplant of sickle cell anemia in our country and worldwide, I guess. And he's also uh, focusing on transplant of benign and malignant hematology. Also, we have the second speaker, Dr. Dennis Kim. He's a professor of medicine, and he's also very well known to us. He's been presenting and visiting our conferences frequently. He's chairman of malignant hematology at Princess Margaret Hospital. He has a great interest with significant contribution in scientific publication in CML. So the first topic is transplant in CML, second topic by Dr. Mohsen, and second topic is innovation in CML by the right person to present this topic is Dr. Dennis Kim. So without further delay, I probably give the floor to Dr. Mohsen Zahrani to start his presentation.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Thank you, Dr. Ibrahim, for the introduction. And thank you for the SBMT for inviting me to present in this webinar. And I'm going to talk about bone marrow transplant in CML management. This is my disclosure. And these are the outlines of the presentations. So as you know, CML is a clonal hematopoietic stem cell disease that results from translocation between chromosome 9 and 22 and the BCR-ABL rearrangement that lead to the proliferation and the development of leukocytosis and the other features of the disease. The incidence of the disease is 0.4 to 1.75 per 100,000 population per year, and in Saudi it's a lower incidence compared to the Western countries, 0.5 cases per 100,000 population, a median age between 45 and 55. The consequences of BCR-ABL will result in increased cell mass because of continuous signaling from the tyrosine kinase, and because of this continuous proliferation and division of the cells, there is genetic instability, and this can lead to the progression of the chronic phase to accelerated and blast phase. There are three phases of the disease: chronic, accelerated, and blastic phase. In the past, the overall survival was dismal compared to the current because of the introduction of tyrosine kinase inhibitors. And this slide shows the treatment development for CML over the last maybe 200 years. In the past, they were treating patients with radiation, then bisulfan hydroxyurea, then from 1970 to 1920, hematopoietic stem cell transplant, allogenic, was the treatment that provide long-term survival. And until the beginning of 2000, with the introduction of imatinib, the first generation tyrosine kinase inhibitors, there was a big shift in the treatment of the CML from chemotherapy, stem cell transplant, to the different generation of tyrosine kinase inhibitors, starting with imatinib, then second generation dasatinib, nilotinib, bosutinib, and then the third generation ponatinib and asciminib. And the introduction of the tyrosine kinase in the management of CML result in significant improvement of the survival, as you see over the years with the red curve, the most recent survival curve, more than 92% of the patients with CML, they live, and it's almost close to the normal population. And also we noticed the significant reduction in the utilization of allogenic transplant in the treatment of the CML. As you see, the red curve below in the figure is declining over the years, indicating less use of allogenic transplant. And the ABMT also, this is a large number of patient, as you see, starting from 2007 until 2017, 10 years span, there is a significant reduction in the number of transplant for CML in different phases. For example, in chronic phase in 2017, it was 164 cases transplanted. In 2017, 74 cases. So there is a reduction in different phases, but in plastic phase, there is still a significant number of cases transplant. Allogenic transplant, it was until the beginning of 2000, was the standard of care for treatment of chronic phase, accelerated phase, and plastic phase. And the introduction of tyrosine kinase inhibitors reduced the utilization of this procedure in the treatment of CML. Efficacy of transplant, this is old, maybe more than like 30 years publication where the outcome of allogenic transplant in a chronic phase, the overall survival was between 50 to 85%, and accelerated phase 30 to 40%, and in the blast phase 20 to 30%. And allogenic transplant is very effective in treatment of the CML because of two mechanisms. Number one is the myeloablative conditioning. It is very effective in eradicating the leukemic blast and the leukemic stem cells. The number two is the graft versus leukemia effect. This disease is very sensitive to graft versus leukemia effect. From different studies, this has been shown, and the utilization of DLI or donor lymphocyte infusion post-transplant can control the disease relapse. Disadvantage of the transplant is the transplant-related mortality, 5 to 20%. I guess in the recent years, this figure is lower than this number. In 2010, maybe like 15 years now, the outcome is better. The overall survival in this large reported study, more than 2,400 patients, the overall survival for patient transplanted for match-related donors, 88%, and match-unrelated donor, 87%. And mortality rate were similar to those of the general population for those who survived more than 15 years post-transplant. This figure shows how the tyrosine kinase inhibitors work by occupying the ATP site on the BCR-ABL by imatinib, and this block the down signaling of the cells and proliferation of the cells. And this table shows, first table shows the tyrosine kinase as the second generation, and first generation in the treatment of chronic phase, and the second table about the accelerated phase. And you see the overall survival at 5 years in the chronic phase is more than 90 or 95%. In the accelerated phase, it is between like 70 to 80%. When to do a transplant at this time period when the main treatment of the CML is with tyrosine kinase, when is the transplant is indicated? There are different guidelines, so we will go over them. The first guideline was from the EBMT. Patient with the blast phase after they achieve the chronic phase is a strong indication. Patient who progressed from chronic phase to accelerated phase, and patient in chronic phase after failure of third-line therapy or with those with T315I mutation. ASTCT guideline, it is a standard of care for accelerated and blast phase and chronic phase number 2, and standard of care with clinical evidence in chronic phase 1 in those who are intolerant or refractory. A British Journal Hematology guideline is very extensive, but similar to the previous guidelines. NCCN guidelines, as usual, per NCCN guidelines, they take the treatment phases into different figures. But here in this figure, it shows the chronic phase. The main treatment is the tyrosine kinase inhibitor for low risk or intermediate risk, either first or second generation tyrosine kinase inhibitors. And the transplant can be considered in those who are refractory or intolerant. In advanced phase disease, such as plastic phase or accelerated phase, the transplant is indicated. And this figure shows those who achieve cytogenetic response post-transplant can consider TKI maintenance, especially those who are positive post-transplant or those who relapse post-transplant. ELN 2020 is it's very good recommendations, and I find it the most clear recommendation to establish. The transplant is indicated in CML chronic phase resistant to second generation TKI, first or second line. At this time, you have to initiate the donor search. It's not essential to do transplant, but you should start thinking about transplant. It's indicated in chronic phase failing to ponatinib after 3 months of treatment. It's indicated an accelerated phase at initial presentation. They are eligible for transplant if the response is not optimal. So if the initial presentation of the CML is accelerated phase, you treat them usually with tyrosine kinase inhibitor. If they don't achieve good response, then you take them to the transplant. And in accelerated phase that progressed from chronic phase, they should be taken immediately for considered for transplant. CML in blast phase proceed to allogeneic transplant after conversion to chronic phase, and CML in frank blast phase transplantation is not recommended. When to do transplant in the past, the outcome of the transplant is much better if it is done within 1 year from the diagnosis. As you see, the survival curve here is significantly different between the time period if the transplant was done less than 1 year and more than 1 year. But now, currently in the TKI era, chronic phase failure or intolerant of TKI, the timing here is not significant, and even some studies showing there is no difference if the patient was exposed to 1 or 2 or 3 TKIs while in their chronic phase. There is no difference in the outcome. Accelerated and plastic phase, once reverted to chronic phase, they should go immediately to the transplant. Regarding the prognosis, this is Grat-Hall score from the EBMT. It is a large registry-based score, more than 3,000 patients, those who were transplanted between 1989 and 1996. So it is old cohort, but they found the variables that are associated with our prognostic regarding the survival outcome is the donor either match unrelated or match related or unrelated, the stage of the disease, either chronic phase, accelerated or blast phase, the age of the patient, the gender mismatch, and the timing of the transplant is the most important, less than 12 months and more than 12 months. And here you will have 7 scores. And according to the scores from 0 to 1, 2, 3, 4, 5 to 7, you see that the survival curve is going down when the patient is having more score. In a recent cohort, they did the same risk factors for cohort from 2007 to 2017. As you see, there is improvement in all risk groups by around 11 to 26%. And here, because of the improvement in the transplant procedure, supportive care, and the utilization of TKI pre and post transplant. What conditioning regimen if you decide to proceed with transplant? The best regimen is myeloablative conditioning, of course, because it has a powerful effect on eradicating the leukemic blast and the disease. And pyrisulfan cyclophosphamide is the standard of care. And in this study, they were comparing pyrisulfan cyclophosphamide to CyTBI. The survival was similar, but the non-relapse mortality was less in pyrisulfan cyclophosphamide. Not every patient will be eligible for myeloablative regimen. So RIC regimen, reduced intensity conditioning regimen, is acceptable, especially in those who are above 60 or those with comorbidities. But here you have to consider TKI and DLI post-transplant to reduce the risk of disease relapse. This regimen example, fludarabine melphalan or fludarabine with 2 days of pyrisulfan or 3 days of pyrisulfan. GVHD prophylaxis, standard of care in most of the protocol, cyclosporine plus short course of methotrexate. T-cell depletion with ATG or with Cambath may increase the risk of disease relapse post-transplant. So it's better to avoid it, especially in match-related donor. But if you decide to go for T-cell depletion, especially if there is match-unrelated donor, here it's preferable to use preemptive DLI post-transplant plus minus tyrosine kinase inhibitor maintenance. especially if there is no GVHD, better to use the preemptive DLI. And in this study, they showed the preemptive use of DLI in 2 examples. It's used if there is declining in the chimeras of there is disease relapse. And it was very effective. Around 80% of the patient, they have long-term survival, and 60% they have event-free survival. And the timing of DLI affect the outcome. If it was used within the first 6 months, is better. If it was used more than 6 months, it is better than if it was used within the 6 months. Donor selection. Now we can go with any available donor, but the best thing is match-related donor, followed by match unrelated donor, and then haploidentical donor can be also used. Regarding the bone marrow graft source, bone marrow harvest is preferable in chronic phase. Peripheral blood stem cells is preferable in advanced cases, and if RIC regimen is used for the advantage of the graft versus leukemia effect, which is more with peripheral blood compared to the bone marrow harvest. Post-transplant TKI, patient transplanted in chronic phase, it is not indicated. Patient transplanted in advanced, accelerated, or plastic phase, TKI maintenance for 2 years can be used, especially if RIC or non-myeloablative regimen is used. Patient transplanted using RIC or non-myeloablative regimen, TKI maintenance is important for 2 years. Monitoring of MRD post-transplant is very important because we have the PCR-ABL, which can be done by quantitative test. And usually we do it every 3 months post-transplant. And in this study, the outcome and response, the positive test in the first 6 months may not predict relapse. The PCR-ABL may persist in the first 3 to 6 months, and then it will disappear without treatment. But positive test after 6 months is predictable of higher risk of relapse. PCR-ABL transcript that increase over time is more suggestive of disease relapse. And those who have positive PCR, their survival is very worse compared to those who have negative PCR-ABL post-transplant. And the pattern of PCR-ABL positivity may also affect the outcome. Those who have persistent elevation, they have the worst outcome compared to those who have fluctuation, compared to those who have negative test. Relapse post-transplant, therapeutic options include, of course, number 1, reduction of immunosuppression if there is no GVHD, use of DLI, donor lymphocyte infusion, and the use of TKI. Donor lymphocyte infusion for disease relapse. This disease, as we mentioned, it is very sensitive to the DLI infusion and the GVL effect, and it can control the disease relapse without any further chemotherapy, especially if there is molecular or cytogenetic relapse. But if there is frank leukemic relapse, you may need to give chemotherapy, as you see in the right side, the upper figure. Those who have transformation or leukemic blast relapse, they have a very poor response, while those who have cytogenetic and hematologic relapse, they respond nicely to DLI. And the effect of the DLI for different diseases, CML compared to AML and ALL, you see the long-term survival for CML is significantly better than AML, MDS, and ALL, indicating the sensitivity of this disease to GVL effect. And another study of around 66 consecutive patients with CML relapsing after allogeneic transplant, molecular remission was attained after DLI in 68%. And those who achieve molecular remission, their survival is 95%, compared to those who did not achieve molecular remission, their survival was 53%. TKI for disease relapse post-transplant. All patients should be considered for treatment with TKI at the time of relapse. The choice of TKI is largely dependent on mutation analysis of PCR-ABL, side effect profile of available TKIs, the patient prior history with these agents, and individuals' comorbid conditions. Some studies showing that patients who did not respond to TKI, for example, imatinib, post-transplant, they may respond. So but most of the recent recommendations, I did not find specific studies, but experiences and recommendation maybe to use like secondary generation or third generation. So in conclusion, transplant is a highly effective therapy that can achieve long-term remission in 50 to 85% of first or second chronic phase, 30 to 40% accelerated phase, 20 to 30% plastic crisis. However, allogeneic transplant is associated with upfront mortality 5 to 20%. Transplant is indicated for advanced phases, accelerated or blast, and chronic phase intolerant or refractory to TKI. Myeloablative conditioning with Beocyte is the preferred regimen, especially with bisulfan level monitoring. RIC and MAC or non-myeloablative regimen is acceptable in those who are above 60 or with comorbidities. Post-transplant TKI maintenance for 2 years is preferable in advanced phases cases. Disease monitoring every 3 to 6 months, and early intervention with DLI and introduction of TKI can control the disease. At time of relapse, all patients should be started on TKI plus minus immunosuppression with withdrawal and DLI. Thank you.
Thank you so much, Dr. Mohsen. Very nice presentation. And thank you for being on time also. Next topic will be innovation of CML by Dr. Dennis Kim. And audience can post their question in the Q&A section. After this presentation, we will have 5 minutes for question. So, Dr. Dennis, please.
Thank you. So, thank you for your kind invitation. Salam alaikum, my colleagues in Saudi. So I'm going to talk about the innovation in CML practice in 2023, especially focusing on new drug development, including asciminib and the next generation diagnostic. That's what I would like to talk today. So this is my disclosure. And this is the topic that I'm going to go through today. So first of all, what I would like to raise is that what brought that kind of significant improvement of CML patients' outcome over the last 2 decades, including the survival and treatment-free remission. I would say it's not just drug development. You can see I put it here, number 1, 2, 3. And you can see here from the 2000, we have 6 drugs currently available: imatinib, dasatinib, nilotinib, bosutinib, ponatinib, and asciminib. However, this is not the only one. The number 2 factor that can improve our outcome in our CML patient is especially the molecular monitoring using the BCR-ABL qPCR. And number 3 is that the development of the recommendation. You can see in 2006 and 2009, 13 and 20, ELN version number 1, 2, 3, 4, you can see the development and progress of that kind of clinical recommendation. They also helped to improve our the patient's outcome in our CML patient. So this is you can see from the version number 1 to version number 4, there's a huge enhancement and improvement of the clinical recommendation. And I can just show you a little bit of detail here. You see in 2006, we have only imatinib available. At that time, the molecular, the milestone treatment milestone was CCYR, but there is a concern for the emerging mutation. And 2009, at that time, still imatinib was the front line, but we can start using the nilotinib and dasatinib, and we would like to incorporate it in our clinical practice. And then you can see in the bottom here, the concern and consideration, the risk of emerging mutation has gone down by introducing the other TKI treatment. And 2003, we start to use nilotinib and dasatinib as a first-line treatment, and we are able to use bosutinib and ponatinib as a second-line treatment, and even for T3155, we are able to handle that. And later on, we can think about using the treatment-free remission in our treatment goal in our CML patients' outcome. And also another thing is that we start to use the major molecular response as a kind of therapeutic milestone. But now you can see in 2020, we have at least 4 drugs available as upfront treatment, and we are now aiming for the DMR, deep molecular response, as our milestone for the CML treatment. And we are now more concerning on an adverse event in our clinical practice of the CML patient. So you can see lots of changes over last 2 decades in our CMA practice in terms of the treatment goal and concern and considerations. So what about in a third line option? In a third line option, as you can see here, on the upper left here, you can find there's some drug available, HQP 1351, PF 114, K0706, which is under the clinical trial. However, you can see bosutinib, dasatinib, nilotinib, ponatinib has been already approved to block the ATP binding site. And on the bottom, you can see that the mystory binding site can be blocked using the allosteric inhibitor called the asciminib. So today I'm going to more focus on the action mechanism of allosteric inhibitor, new class of ABL1 protein blocker called the asciminib. And let's just talk about its action mechanism first. So left side, you can find the active ABL1, which has three portions. One is kinase domain, and the other one is SH2, and the other one is SH3 domain. And you can find here, at the end of SH3 domain, there's a protein called N-terminus. This N-terminus can bind to mystory pocket, which is located in a kinase domain in ABL1 protein. So when N-terminus bind to a mystory pocket in a ABL1 protein, then the protein itself is going to be transformed to an inactive form. That's why we call it mystory pocket does have an auto-inhibitory function to cool down the whole ABL1 protein. However, what happens once the BCR-ABL transcript, the fusion event happened is that then the end of SH3 domain, where the N-terminus was located, which will be fused with the BCR protein, and you can see BCR protein is much bigger than the N-terminus. Accordingly, it cannot fit into mystory pocket. Then the whole BCR-ABL1 protein is going to be constitutively active, and it start to activate all the signal transduction pathway, which will make the whole CMS cells to proliferate further and further and further. So the idea comes up, why don't we try to try to mimic this N-terminus? They found, they developed the asciminib as a kind of alternative potential candidate to block the N-terminus, to block the mystory pocket. And actually, it worked very well. After using the asciminib, you can see on the right side, inactive ABL1 protein is going to become inactive because it can have an auto-inhibitory function. That's the action mechanism of allosteric inhibitor. Then you may say that another beauty is that still ATP binding site is opened, so there's a potential combined use of asciminib with the other ATP binding inhibitor to block any resistance in this case. So, however, what is the benefit of using the asciminib, which is predominantly just focusing on the mystory pocket, not the ATP binding pocket? Now, this figure tells you that how the ATP binding pocket is presented in the human proteins. In human proteins, lots of proteins, they are using the ATP as a source of energy. And you hear that ATP is a source of energy of the cells. So once you block the ATP binding pocket, it is blocking not only the ABL1 protein, you also block the lots of other proteins as well. So you can see from the left side, the imatinib, to the right side, to the ponatinib, you can see all that kind of red dots, red circles, which means that it blocked not only the ABL1 protein, but also all the other kinds of protein, it will be blocked. That's the main issue for the blocking of ATP binding site. So you can see lots of, can you see my cursor here? Yeah, you can see here, in case of BCR-ABL specificity, in the top row here, asciminib, the red one is BCR-ABL positive cell, and the blue one is BCR-ABL negative cells. And you can see there's a huge gap between this red circle and the blue circle here, which means that the CMS cell is more specific to asciminib. In a very low concentration, it can easily be very, very sensitive. However, non-CMS cells, it is not that much sensitive. You can find it. But in other cells, in other compounds, such as imatinib or nilotinib or ponatinib, you can see lots of overlapping, which means that in the concentration where the CMS cell can become sensitive, but then the other cells, the other non-CMS cells, also they will be also very sensitive to the concentration where the CMS cell is going to be sensitive. It means that then with the imatinib, nilotinib, and ponatinib, the patient is going to have a lot of off-target side effects. But then you may say bosutinib and dasatinib doesn't have that kind of overlap. However, you can see their therapeutic window is very, very narrow, which means that in the concentration where the CMS cell is going to be killed, probably the non-CMS cell also going to be affected with that concentration. But now then you can look back to asciminib here. There's a lot of gap between in terms of their therapeutic concentration between the CMS cells and non-CMS cells. It will be translated into a clinical benefit in terms of tolerability of asciminib in our CML patient. So let's review then the clinical data of asciminib in a third-line setting. So I'll just quickly go through the ASSEMBLE study, which has compared the asciminib versus bosutinib into 2-to-1 ratio here. And the primary endpoint was, as you can see here, MMR at week 24, which is equivalent to a 6 months MMR. And in the patient who failed the bosutinib, they are allowed to switch over to asciminib, and they can be continued. And there is now the median follow-up duration. There's now the long-term follow-up data at around 2 years after the randomization. I can show you some data about that as well. So this is the patient's disposition. To make a long story short, in the group treated with asciminib, you can see roughly 55% still they are getting a treatment ongoing with the bosutinib. Just 20% of the patient, they will remain on bosutinib, but 80% they already stopped the treatment of bosutinib. While with asciminib, just 45% of the patient, they stopped the asciminib treatment. And you can look at the reason for the discontinuation here. Lack of efficacy, 24% in asciminib, but it was much higher in the group treated with bosutinib, roughly around 36%, and adverse event, 7% with asciminib, but bosutinib, 25%. So now you can see there is a consistent signal of showing that the therapeutic benefit of using the asciminib over the bosutinib as a third-line treatment or higher level. So this is the primary endpoint, as I have shared, week 24, which is roughly around 6 months. There is a higher instance, a higher rate of MMR at week 24 with asciminib, 26% versus 13% with bosutinib. So the MMR rate was actually 2 times higher in comparison to 2 times higher with asciminib in comparison to bosutinib. And now you can see the key secondary endpoint, week 96, which is roughly around 2 years. And you compare 25% of the MMR at 6 months with asciminib has increased up to 38%. So still there's a continuous increase of MMR rate with asciminib. But once you look at the MMR rate of bosutinib, it was 13% at week 24, which has not shown that much of change at week 96 at 16%. So the MMR rate with asciminib increased consistently over time. It suggests that maybe a continuing treatment with asciminib has some long-term benefit. What about event-free survival? Event-free survival is a kind of composite endpoint, and you can see here lack of efficacy, disease progression, or discontinuation due to adverse events. So it is a composite endpoint, and you can see it clearly shows the event-free survival rate at 2 years is around 60% in case of asciminib, but it has gone down to 30% with bosutinib. So there is a benefit of using the asciminib over the bosutinib in terms of event-free survival. That will reflect not only the efficacy, but also the tolerability. So in terms of overall AEs, as I have already shared a little bit in the beginning, you can see 7.7% of the patient on asciminib, they have to stop the asciminib due to adverse event, while that chance is much higher with bosutinib. It was 26.3%. 26.3% of the patient has to stop the bosutinib due to adverse event. So I'm not going to go detail about their side effect profile, but you can see the liver enzyme elevation was not that much higher in a asciminib group, while it is one of the main reasons for the discontinuation in case of bosutinib treated outpatients. So what about the quality of life? So this is actually my favorite slide in terms of whenever I present about the sample data. So now you see, let me just explain about this figure. So on the left side direction bar means that they have a less frequent symptom. So there is an improvement of the symptom. However, if the bar is facing the right side, it means that there is a worsening of the symptom. So for example, once you look at the fatigue, so then the green one is facing the left side, which means that asciminib seems to have less fatigue in comparison to prior to the switch over to asciminib. And now you see all the green bar is actually facing the left side. Fatigue or muscle soreness or malaise and everything seems to be improving in terms of their quality of life. Bosutinib, you can see some facing the left, some facing the right. So still, it is still, you can expect that there would be some improvement of some symptom with the bosutinib, but in some case, there is a worsening of their symptom with the bosutinib. And it is very difficult to predict who is going to end up to have that kind of changes. That is the reason that this is exactly the same with the comments from my patient. My patient, whenever they switch over to asciminib, and in their first visit in 2 weeks after switching over to asciminib, they always bring that kind of comment. Oh, I don't feel any side effect. I used to have a lot of other kinds of side effect, but after switching this medication, then I don't have that kind of issues anymore. So that is what I usually get from my patient after switching over to asciminib. And I think that this slide is reflecting my clinical practice very well. Then what about, and you may say that, oh, is there any data to compare the asciminib versus ponatinib? So this is the data. So we don't have any prospective study, but we do have some real world experience data. You can see up there this is the data from the use of ponatinib, and below here this is the data from the use of asciminib, and now you can see the MMR rate and MR4 rate, and which is quite similar. So this is MR2 and MMR and MR4, and you can see the number is not that much of a big difference. Number one is that similar MR2 CCYR rate was observed between ponatinib versus asciminib based on the real-world experience. However, the cardiovascular risk was not properly compared between the two groups. So when you interpret the data, you have to be very careful about the interpretation of the data. That's number one. And number two is that, but you see here, the response based on the prior ponatinib use. So it doesn't have that kind of information here in the patient treated with the ponatinib, but you can find some information here comparing the response rate prior to ponatinib exposure versus ponatinib naive patient. And you can see that the ponatinib naive patient, they have a little bit of a higher response rate in comparison to any patient failed the ponatinib prior to the asciminib. So another conclusion is that ponatinib pre-treated asciminib patient showed a little bit of lower CCYR MMR rate compared to ponatinib naive patient, but it still showed around 17 to 48% of MMR rate with asciminib, which is also very promising. So there is no head-to-head comparison, and I do not think that we are going to have that kind of a prospective study evaluating between these two compounds, but probably based on the real-world experience data, we might be able to get some conclusion. Anyhow, when you consider the second generation TKI, resistant case, and you consider the third line treatment or beyond, I think that the number one issue is that you need to consider the depth of response and resistance. And my practice is that if they have a suboptimal response, because you have to worry about their tolerability and their toxicity, I definitely prefer to go ahead with the asciminib because asciminib is still really good drug. Asciminib is a really good drug and very tolerable, and you can go ahead. If they have a low level of response, then you may have to still asciminib will be preferred. But I think that in the maybe you can also consider the ponatinib. However, if they are the one who is a primary refractory patient, still we have to make a balance. But you also can think about the using of a ponatinib in that situation. But another factor is that if they have a cardiovascular risk factor, especially if they have if they are high risk for cardiovascular disease, then definitely asciminib will be preferred over the ponatinib. I think that it is very consistent with our Canadian data. Canadian data also suggests our Canadian real world experience data also suggested that out of 22 patients who had a past history of cardiovascular disease, not the risk factor, but in the patient treated with asciminib, we didn't have any patient who has to stop the asciminib due to cardiovascular event issues. And their response rate is quite similar to those who didn't have any cardiovascular event in the past. So I'll just show you some real world experience data here. So this is the case, 61 years old patient, initially diagnosed with chronic phase CMA in 2015, initially treated with imatinib, but suboptimal response 2.1 log reduction and switch over to the dasatinib, but patient start to experience pleural effusion and reduce the dose several times and stop the dose and then re-escalate the dose of the dasatinib. But patient developed the loss of molecular response completely, but there is no ABL1 kinase domain mutation. And we challenged the patient with asciminib and patient achieved a really good response. Now patient achieved around 3.8 log reduction and patient is maintaining very well. But in that case, one of the reasons that we would like to go ahead with asciminib is that patient had a Framingham risk score of 16.8%, which correlated with their in future cardiovascular toxicity. That is one of the reasons. You can see blood pressure over 156 and a little bit of higher cholesterol level, etc., etc. And patient is now doing really, really well with asciminib, and the patient is very happy about that. And you can see here, in this patient already failed the imatinib, already failed the dasatinib, but because of cardiovascular issues, you are not going to go ahead with the nilotinib, and you are not going to go ahead with the ponatinib. In the patient developed pleural effusion with the dasatinib, if you try bosutinib, then probably their chance of having another episode of pleural effusion will be around 50%, 50%. That's another reason that I decided not to go ahead with the bosutinib. On top of the result from the ASSEMBLE data. ASSEMBLE data already showed that between the asciminib versus bosutinib, asciminib is superior to bosutinib in terms of the efficacy and tolerability. And that is the reason that in this case, I went through asciminib as a treatment of choice, and the patient is really doing well with the TKI switch to asciminib. So then I will just quickly show you next maybe a 3-4 minutes. I'm going to talk about newer drug development, and this is the newer drug development on the pipeline. And I want to share a little bit of information about the HQP1351 oliberambatinib. This is the third generation TKI, and it is ATP binding inhibitor. However, it is also effective for the T315I. And it has been already approved by the FDA in China, but not in other Western countries. But the beauty of this one is that it doesn't seem to increase the risk of cardiovascular toxicity based on the publication. And you can see here, the MMR rate seems to be pretty good. 60% of MMR in chronic phase and 40% of MMR in accelerated phase, which is a very promising result. So we look forward to hear some other study that is currently running in Western countries. Another drug is a bodobatinib. Bodobatinib is another ATP binding inhibitor, and its beauty is that it is also effective for other mutated BCR-ABL, and it has very limited off-target activity. So you can expect that this is a well-tolerated drug, but based on the phase 2 data, its efficacy seems to be slightly lower in comparison to oliverambatinib. So it has been done phase 2, but I'm not sure this drug is going to be further developed in this setting of CML disease. Another one is the barmotinib. It was called the PF114, and this drug has been developed in one of the pharmaceutical company in Russia, and now you can see this drug is also working for T315I. 5 out of 16 patients with T315I, they responded. And another beauty is that out of 5 patients who failed ponatinib before, 3 patients, so their response rate with barmotinib in case of ponatinib failed patient is around 60% based on their study outcome. So this drug is also very promising, but I'm not sure about the further development plan for this compound. Another one is the ELVN-001. ELVN-001 is another compound mainly focusing on the ATP binding site. But as you can see here, this is IC50 for other off-target kinase, and different from the other compound here, ponatinib, nilotinib, dasatinib, and bosutinib, it is blocking the other kinase a lot, c-KIT or FLT3, PDGF, VEGF, and SRC, which means the patient is going to have a lot of other side effects through that kind of off-target inhibition effect. But once you look at here, ELVN-001, it doesn't seem to have that kind of off-target side effect. In other words, it will be very clean drug without having any off-target side effect. So this drug is also very promising. Another one is TERN-701. TERN-701 is another class of allosteric inhibitor. So it is also blocking the myristoyl site, not the ATP binding site. So we will hear more about this drug maybe next 2 to 3 years. So the last part of my talk is about the ELN laboratory recommendation in 2023. It has been recently published, so you will know about this. So there's a publication, European Leukemia Net Laboratory Recommendation for Diagnosis and Management of CML, and it is the first time to mention about how to utilize somatic variants beyond the ABL1 kinase domain mutation using our NGS panel. And it clearly mentioned that the routine screening by myeloid NGS panel at the time of initial presentation of a CML in chronic phase is not considered as a standard of care, but can be considered to be a research. So as you can see here, ASXL1, LUNGS1, TAT2, DNMT3, or that kind of mutation can be detected in a roughly around 30% of chance in a chronic phase CML patient, but still we do not consider it as a standard of care at the time of initial diagnosis. So now, however, if they present with a de novo blastic phase CML, or in my case, I also activate it in case of advanced disease, including the accelerate phase, then I activate and try to find out ASXL1, LUNGS1, BCOR-L1, or Icarus gene mutation that can be detected up to like a 15 to 20% of the case. And that is also very, very diagnostic and very confirmatory to make a diagnosis of blastic phase CML transformation. What about during the course of the disease? So at the time of initial diagnosis, as I mentioned, it is not recommended as a standard of care for chronic phase, but it can be considered in case of de novo blastic phase or maybe accelerate phase at the time of initial diagnosis. But during the treatment, then if there's any sign for the resistance or disease progression, then you should consider the use of NGS testing. NGS testing is suggested. What is the benefit? The benefit is that then it will confirm the diagnosis of blastic phase transformation, number one. And number two is that in some case, it will disclose some additional therapeutic targets, such as IDH1 or 2, for which you can utilize IVO or ENA to block those kind of mutation as a targeted treatment. So there's some potential benefit of using that. And in our center at PMH, we are using our own in-house panel called the SME panel, but just for the research purpose. And we are now trying to accumulate those kind of information. So maybe, and we are going to also present some data. We already presented some data in the ASH meeting last year, and this is the data. We have a look at the 140 follow-up samples, and out of that 140 samples, we have 39 samples which was collected at the time of resistance or progression, and we have 100 samples at the time of optimal response. And now you can see here, the frequency of that kind of mutation was so much higher in the patient already progressed or resistance. That number was around 44%, versus you can see only 22% of the case showed certain mutation in case of optimal responder. And it was especially true in the mutation on activation signaling or myeloid transcription factor pathway. And it has been already presented in the ASH meeting last year. So this is my take-home message. Number one is the significant improvement in the treatment outcome of a CML patient. They will include they will include the drug development, molecular monitoring development using BCR qPCR, or clinical recommendation development and its implementation into the clinic. And the second one is that new class allosteric inhibitor has been already approved as a third-line therapy or beyond, and asciminib cannot be simply improve efficacy in the third-line setting or beyond, but also it increased the tolerability by reducing the toxicity. And number three is that I mentioned about some new drug development, such as oliberambatinib, vodobatinib, bamotinib, and ELVN-001 and TERN-701. And the last part was that ELN Laboratory Recommendation 2023 provides some statement regarding the use of NGS-based somatic mutation profiling in the clinical management of the CML patient, and is suggested to be done in advanced disease at initial presentation, or any patient progressed to advanced disease during the TKI treatment, but not for the patient in chronic phase at the time of initial diagnosis. But it can be still recommended as a research test. I think that this is my last slide, and thank you for giving me a chance to give a talk here, and I'll be happy to take the question from the audience. Thank you.
So thank you, Dr. Dennis Kim. Very nice presentation. And also thank you to Dr. Mohsen again. We can start the Q&A session. So I think I have a question for Dr. Mohsen from Dr. Fahad Bakari. He's questioning about the role of maintenance in chronic phase. You mentioned chronic phase does not need maintenance, but what about if there is BCR-ABL or detectable disease after transplant in chronic phase patient? Do you still recommend no maintenance?
So as I mentioned, if there is like appearance of BCR-ABL, it depends on what is the period post-transplant. In the first 3 to 6 months, it doesn't have a lot of significance, but after 6 months post-transplant, it can be significant and correlate with further progression. So in these cases, number one, you have to withdraw immunosuppression if there is no GVHD. Number two, DLI is the number one to use in the treatment, and of course, TKI should have also a role here, and you will maintain them on TKI. And then we don't have clear guidance. Can we stop if the patient achieve MMR or complete molecular response? We don't have, because there is limited evidence here. But I assume in these cases, I will continue with the TKI if there is no toxicity to avoid further disease progression.
Thank you. So another question is regarding GVL effect is mentioning that CML is very sensitive to GPL, so why we still need MAC? So can you consider RIC for some patients?
When you use MAC, especially in young patients, you have two benefits, the myeloablative conditioning and the GVL effect. In the first trials of transplant for CML, it was with autologous transplant. And autologous transplant by itself, in initial studies, it showed some control of the disease. And then you'll, especially if the patient is young, but the way to go is with myeloablative regimen. Yeah, I think this will be. But in those patients who are with comorbidities older than 60, you can use the RIC, and there is more utilization now of RIC in this setting.
Thank you. So here a question from Dr. Mohanad Al-Humayt to Dr. Dennis Kim. First of all, he thanks both speakers. Then for Dr. Kim, do we have any data for asciminib regarding CNS penetration? And another question, also combination with chemotherapy or BiTE for blast phase, and use of asciminib post-transplant. So this is 3 questions. So first one is regarding CNS penetration.
Yeah, thank you for asking the question. So in terms of the CNS penetration, asciminib cannot penetrate the BBB. So it cannot be used for the CNS disease, number one. And number two is the combination with the chemotherapy. I think that the company is now trying to generate that kind of data in the context of the Ph positive ALL. But if we are now talking about the combination with the other TKIs, which is one of my research topics, we still have to wait for some clinical data to come out. But in vitro data already suggested that there would be some beneficial of combining the 2 TKIs to eradicate even certain ABL1 kinase domain mutant CMS cell lines. About the BiTE, I don't think there's any data about the use of BiTE, but it will be a matter for the future research.
Thank you, Dr. Kim. What about post-transplant asciminib, post-transplant, any data?
So post-transplant asciminib, we don't have any data. However, my assumption is that it would be really, really helpful because I don't see that much of, in some reason, I don't see that much of issue in the patient getting asciminib, but with the other calcineurin inhibitor, I don't see that much of organ toxicity. So to me, I think that the use of asciminib in a post-transplant setting, it will be very, very beneficial because as you have seen, it is good for the quality of life and their tolerability is good. And even you can start the asciminib in the patient already on some calcineurin inhibitor, but it doesn't interfere any drug-drug interaction. So I think that there will be some beneficial effect. However, the clinical data is lacking right now.
I will add, especially if the patient is refractory to all lines. I just today have a patient post-transplant with progression, so he was refractory to all lines, and I'm planning to start asciminib. So this is clearly indicated in this case.
I support the use of asciminib for that situation.
Yeah.
Thank you for sharing that information, Mohsen.
Thank you. Thanks.
Okay, so here Dr. Sara Al-Ammari is asking Dr. Kim about the use of asciminib in patients with chronic kidney disease or end-stage renal disease.
There's a data about the dose reduction of asciminib in case of chronic kidney disease. You don't need to reduce the dose. You don't need to reduce the dose of asciminib just for the kidney issues. But I'm not sure about ESRD. So liver toxicity or kidney toxicity, asciminib can be used safely without having any dose reduction. That's what I know about their pharmacological data.
So thank you. So I have no more question here in the Q&A. So if any one of the panelists would like to ask question or comment before we conclude.
Thank you. Thank you.
Okay, so
I
at the end,
really
I'd like
enjoyed your talk, Dr. Mohsen.
Thank you, Dennis. Thank you.
So again, thank you for both of you, Dr. Mohsen and Dr. Kim, for very nice sessions, and also again thank for Saudi Society of BMT and Novartis for sponsoring this meeting. And I'd like to remind you about the next webinar will be on Sunday, December 3rd, same time, about reshaping of CML and CML unmet needs and challenging cases. So you are actually welcome to join again this session. And at the end, I would like to thank all attendees for attending this activity. We'll see you, inshallah, next meeting.
Thank you.
Thank you.
Thanks a lot.
Bye,
Thank you.
Dennis.
Bye.
See you on ASH. Bye.
Bye.